Thank you very much. Dean has got a question.
Thank you, Chair. And may I just say, James, Darren, thanks for your powerful testimony earlier. It was very moving. Helen, my question, it ties into the previous questions in a way, but it's about how does the learnings from these awful incidents get fed back right into the start of training? Because it sounds to me like a lot of the challenges here is that it waits for an incident to happen, and then there's a court case or whatever, and then the learnings then could be months, if not years later. I understand that might then be reported back to the trust and perhaps that's shared more broadly, but is that also being shared right back at the early stages of training for new doctors and nurses and maternity staff?
Thank you for that question. I think that there's two things there. The first is the Royal Colleges have a big role to play there. Royal College of Obstetricians has something called Learn and Support, which we feed information into, which aims to get to obstetricians in training so that they can pay attention to the lessons that come out of legal claims to feed into their sort of everyday practice. So there is a route there through the Royal Colleges, and the Royal College of Midwives as well has a role to play there. I think the area of training that we're most keen to get involvement in is skills in delivering, engaging with families and communication skills, and that's something which we think is probably lacking in professional training at an early stage. We hear that people have this sort of ingrained belief, for example, that you shouldn't admit liability on a case, you shouldn't be open with a family because it might result in litigation. That's something which we've constantly tried to debunk and to encourage candour. Now that's something I think which could be built far more effectively into clinical training.
And can I just ask very briefly as well, just around near misses, because I imagine, in these awful cases like we've heard today, the worst possible outcome happened. But I imagine there may have been very many other examples where the ultimate outcome wasn't the same, but actually the lead up to it could have been. And I just wonder whether there's a monitoring of those near misses once you found out what the pathway was to these awful cases.
Yes, it's an interesting question. 50% of the cases that we get don't result in a compensation payment, and we only see the tip of the iceberg, with lawyers generally only put forward 1 in every 10 cases that they see. So there's an awful lot of information there which is relevant but hasn't resulted in a compensation claim. I think, again, that we only see the thin end of the wedge. We don't get to see the many incidents which would happen, or the near misses that happen in the NHS, which don't come to us as a claim as well. And that's where I think the role of incident reporting and the work that NHS England and Improvement are doing there is extremely important.
A final one from Dean on this, and then we'll move on to Sonia McLeod, who's been very patient.
Thank you, Chair, and thank you, Dr. Vaughan. My question is just about this culture of learning that we've touched upon. We live in a digital age, and it sounds to me, from everything we've heard so far, is that this is very much about a person-to-person reporting up concerns and issues. And as I understand it, the NHS has well over 1 million members of staff. Has there been any investigation or look at the use of technology to enable people to who are staff anonymously report concerns or share learnings or identify areas for an improvement? And if that has been looked at, I'd be interested to find out. If not, is there a thought on why? And my attached question to that is that is there a concern, do you think, that actually if every member of staff shared a learning or a concern about issues, that actually it could open a Pandora's box of problems that actually it's easier to be ignorant of rather than actually address?
I think the first important thing to say there is that actually there should be a presumption of good intention until we go anywhere else. Most staff, when they come in the NHS, they're coming in to do a good day's work. And when you look at error, and I'm not an expert in error, but I know people who have, when they've looked at those, they've found that, there are hundreds and thousands of errors that could happen each day. And they only don't happen because of the good intentions of the staff. And the other worry is that we shouldn't be driven just by outcome. We become suddenly very focused on if someone dies or some awful thing happens. But actually our approach, whether something doesn't happen or it does happen, should always be consistent in each case. And bringing that consistency in is really fundamentally important, because if you don't do that, you end up with people just being horribly reactive to when bad things happen. And that's why you get the culture of fear. I think technology has a great deal to do with this. And we already have the Datix system in our hospitals where people can register things. But I can tell you, and you won't be, sadly, you won't be surprised about this at all if I told you that Datix is also used as a weapon in healthcare. And I have a feeling that if I wandered into a Swedish hospital, that wouldn't be the case. So they are obviously doing something really right there. And we need to just have a look, very careful look, and look at how we do it, because we've got the stuff in place. We've got Datix, we've got the right, we've got committed staff who in general have good intentions. And it's about using all of that. And I absolutely believe that I know that if you look at, particularly in maternity, if you look at a lot of the times when things have got wrong, simple things like the doctor there didn't have the full notes of that patient's pregnancy, wasn't aware that the baby wasn't growing, quite well at this stage because they didn't have the notes and they were dealing with all sorts of other things at the same time. Very simple things like streamlining patients' notes, having access to full electronic notes, I think would help that. So there are very simple errors that actually software and technology could really help us with, but it's not all the answer. It's not the whole answer. The whole answer, the answer has to include good intentions, not just being focused on bad outcomes, and trusting staff and really studying hard, other nations who have obviously got this, they've got this just culture more in place than we have, and learning from them.
Thank you, Chair. My question is just about how all this ties together across the NHS and social care. We talk often, especially today, about the compensation to families. But obviously the lifetime, especially for babies and children who have been severely disabled, that's going to affect their life for decades to come. The cost to the system of that is immense as well. And I just wonder whether there's been any economic assessment of the cost to the NHS and social care for when failings happen, and also how that's factored into putting a similar amount into prevention so that these things don't happen in the first place. So obviously when we talk about figures like millions being used through compensation, obviously that's essential for the family, but of course there's underlying cost there as well.
Absolutely, and yes there has, and I am probably not the best person to talk about the detailed economic analysis. I'm afraid I'm not an economist, but certainly, I think the one thing that is incredibly clear is that harm prevention, reducing numbers down to the bare minimum, is by far and away the most effective option and use of money that we could do. And I think we're very clear that Sweden's rates are far lower than ours. So this can be done. But I think in terms of prioritising the cost-benefit analysis of each of the interventions, I'm afraid that's more detailed economics than I'm capable of.
Thank you. No, thank you. I'm just very interested to know whether, as well, but forgive the question too if you don't know the answer, no problem. But it's just around whether these costs are looked at both from the NHS and the social care side of things, because a lot of support is given at home and through care outside of hospitals and GP surgeries.
Sorry, please go ahead, Sonia.
Sorry. The other thing that I would say is we have international comparators as well. So, I think we look here at what we do, but we also need to look to other international comparators, because there are birth injury compensation funds in the United States. There's one in Florida, there's one in Virginia. There are schemes like the Swedish scheme, and there are schemes like the Accident Compensation Corporation in New Zealand. And each of those have different balances of providing social care provision, providing nursing care, providing healthcare, home adaptations and things like that. So it's not like we are the only place that we can look to. We can look outside the UK. But as I say, it is far more nuanced and detailed economics than I do, I'm afraid.
Sure. No, thank you very much.